So yeah, I want to thank you for coming and thank you for listening. I'm going to talk to you about our premature son and the experience that we had in the NICU and some of the ethical dilemmas that were surrounding it. And so I'm going to, let's see, can we turn the lights off? We've got him off the dopamine now.
That's what Mary was saying.
Yes, and that means his heart is keeping his blood pressure up at the right level by itself.
Okay.
And his blood is a little on the acidic side, so giving him sodium bicarbonate for that.
Already he's getting baking soda, huh?
Yeah, and he's been getting a lot of transfusions lately, just because, well, his body only has about 3 tablespoons of blood in it.
Is that all?
Yeah.
3 tablespoons, wow.
Yeah. Okay. Well, this video was taken when our son was about a day old. The 2 voices on there are mine and my father's, talking about Gabriel and his condition. It took quite a bit of work to get to this point. When we checked in at 21 weeks and 4 days of gestation with Miri having preterm labor, we were offered to have an abortion several times, and we said no. We wanted to try to save the child. And they said, okay, you've got a 50-50 chance of making it to 24 weeks, at which point there would be a 50-50 chance of the child surviving. And we said we wanted to go ahead and do that. When we got to 22 weeks and 6 days of gestation, Miri's water broke, and we got a visit from a neonatologist or a pediatrician who specializes in premature babies. And here is what he said at that meeting. I don't recommend that babies should be treated at this stage because the results are so poor. If you give birth after midnight, I'll be the one who comes and does the resuscitation, but my heart won't fully be in it. So this caused us more than a little bit of stress, being concerned that, first we already knew that our child was in extreme danger at that point, but then the added question of whether we could get life-saving care provided to him at the hospital was a second question. And, we'd never thought about the question of a premature baby before that. At that point, we thought that the March of Dimes still worked on polio. And it was only later that we got the March of Dimes peer support and discovered that they do, their big deal now is premature babies. So that led me to one obvious question, which is, can the doctor do that? And that's the primary dilemma that we're going to be talking about tonight, is what do you do? Well, first, how does it happen that you have the parents on one side and the doctor on the other side for providing treatment? And how is it you understand, and how do you navigate around this problem? So how can this occur? Well, this statement here is taken from the American Academy of Pediatrics National Standards for Neonatal Resuscitation, and it provides a number of conditions in which resuscitation is not indicated, and not indicated means you shouldn't do it. And some examples here include extreme prematurity, a gestational age of 23 weeks or less, and a birth weight of 400 grams or less. And then it lists off several other conditions that could also be reasons to withhold treatment. Gabriel, at this point, when he was born, weighed 652 grams, which put him into the 97th percentile for size, which, if you can believe, they blamed on me. So, what this tells us is that the doctor, in this case, was in fact acting within accepted national standards when he made this recommendation. Well, why would the doctor say such a thing, and why would the standards be written that way? What I've provided here is the survival statistics from a study done in Japan on premature babies. which found that in the 22nd week, 63% of babies died, and 73% of babies either died or had profound neurodevelopmental impairment. Also, in the 22nd week, 12% emerged with minimal or no impairment. As you advance through the weeks, you find that survival improves steadily with each passing week until you get up to the 25th week, at which the survival or the death rate is only 14%. This study comes from Japan. And the reason I use Japanese statistics is because in Japan, 22nd week preemies have been routinely resuscitated since the 1990s, at which point they had a specific law change that indicates that it should be done in the 22nd week. In the United States, the results are more of a mishmash. And we were provided statistics that were considerably gloomier than these. I believe we were told that our child had about a 20% chance of survival at 23 weeks and 0 days of gestation. And and also these statistics are quite a bit newer than in 2012, which is important in a field as new as neonatology. And the statistics that we were provided from the hospital were more in the 2000 to 2003 range. What the doctor was telling us about was futility, and doctors are not required to provide treatment that they believe is futile. And futility, in medical ethics textbooks that I've found since then, is defined as care unlikely to benefit the patient or treatment to provide poor quality of benefit. The second one took a little bit of time for me to get my head around what that really meant, but what they mean is, for example, you can provide CPR for an hour on a patient who's non-responsive, and there's a slight chance that patient might revive, but if they did, they'd almost certainly be brain dead at that point. So if you return a brain dead patient to a family as the result of your treatment, you have provided treatment of poor quality, of benefit. Another factor in dealing with this dilemma was the time crunch, because you have to make a decision about the child. Our child, in the case of our child, the child was just fine before birth. Everything in the ultrasounds and all the other testings indicated a very healthy baby boy in there, perfectly active as he should have been. The only problem was preterm labor. And as most preterm labors are, about 60% of them, they're considered spontaneous, or there's no known condition that was causing it. It just happened spontaneously. So this futility that we were talking about was over problems that were not yet experienced. Our child was fine at the moment we were talking. However, he was about to come through an extremely dangerous, precarious series of treatments and conditions that he would get. And so the decision to potentially walk away was something based on what was about to happen, not what had happened. What this presents is what some medical philosophers call a window of death, in which you can take actions or refrain from taking actions knowing that it will result in the death of a person. Or you could look at it in another sense of sort of getting away with walking away from a person. I view this as similar to the dilemma that's posed by a Down syndrome baby. In this country, 67% of Down syndrome babies are aborted after Down syndrome is detected in the womb, as people say that it would just be better for a person with this kind of disability to not come into the world, to not be a burden on the family. I viewed this as a similar kind of decision that I could make, or that we could make, to walk away from a potentially disabled child, which we also viewed as taking advantage of the disabled at their weakest. However, you also have to look at it the other way when you're considering a dilemma such as this, which is, are you perhaps reducing the suffering of someone who is likely to die, especially given the more than likely outcome that we were given that Gabriel would die simply because of his extreme prematurity. We also have to think about the autonomy of the patient versus beneficence in this case. Early in the pregnancy, the focus is on the mother's autonomy. As the pregnancy advances, the change goes to balancing maternal-fetal best interests. Around the time of 22, 24, 26 weeks, the baby is considered a person who can survive, and so the doctors have to consider that person's best interests, sometimes independently of the mother's. And so it puts an especially big, strong, or sharp dilemma here as to who is in charge of the baby's best interests in this case, and to decide who's with those best interests, who are. Oh, I'm getting all tongue twisted now. I'm blaming the chocolate. Anyway, let me just skip forward. Consider two adult care examples. Breast cancer patient with a 30% chance of survival, but the doctor says, sorry, no care, it's just not worth it. Would that doctor be allowed to say that? Or conversely, if you tell adult patients there is a 30% chance of survival, there's a 5-month treatment, the treatment's very uncomfortable, and disability is likely with survival. Would all those adult patients say yes? I don't know if I would say yes. And in fact, that is something that nagged at me continuously through our time in the NICU, is have we made the best decision for our child? And looking at all the tubes and wires into him, are we just torturing this child for the purpose of having a child? And technology is not going to make this problem any easier. In fact, it's going to make it worse. Eventually, you are going to hit a wall where it is hopeless or nearly hopeless, in which resuscitation would be certain to not provide any benefit. And also, future technologies include an artificial placenta. There are medical technologists trying to modify or develop an extracorporeal membrane oxygenation device, or ECMO, that can be used to provide nourishment to a baby, and also to be kept in a vat of artificial amniotic fluid. And some 20 or 30 years down the road, you may see someone trying to save a 20-week preemie this way. And at that point, well, the question is, do you do this or do you not do it? Well, you could save somebody's life, but at the same time, whoever's going to be the first person to undergo this treatment is going to have an awful time of it. And the question is, are you providing needed care, or are you experimenting upon that person? At our antenatal counseling session, when the neonatologist came and talked to us, we were provided with statistics about outcomes, especially about the abilities of children who are born at various gestational stages. The categories were unimpaired, moderate to severe neurodevelopmental impairment, severe to profound neurodevelopmental impairment, and death. These categories were somewhat helpful to us, but when you're a parent in crisis, going straight from wondering about crib color to life and death, the whole notion that things might not be perfect, well, these terms sound more like death, almost dead, and life without parole. Years later, or sometime later, we did find out more about what these various groups of statistics mean, especially moderate neurodevelopmental impairment, which is defined as scoring less than 75 on the Bayley Developmental Index of child development. And in fact, our child did score below a 75 a few times. And that meant that he had fine motor skills delays, he had speech delays, he had delays in walking. And I just have to say that, looking back, the notion that when you are talking about providing or withholding life-saving care, that the notion that moderate neurodevelopmental impairment should be in that conversation struck me as kind of offensive. That's a possible reason that you might not want to provide care to the child. These groups of statistics did not provide us with information that we wanted about what it's like. Okay, he might be impaired, and there's this nasty adjective in front of it, but what does that really mean? What does that mean about his quality of life? What does that mean about how he interacts with others? And so that became a topic that we, later on talked with the hospital about. After Gabriel had been home for a couple of years, we were able to organize our objections to what happened in the NICU well enough to write a letter to the ethics committee. And the ethics committee chairwoman wrote back and offered to meet with us, and we did that several months later. And it was a very productive and helpful session, and I'm very glad we did it. Some of the things we found, or that we got from that meeting, were learning that the 23-week and 0-day line in the sand was gone. Instead, they go put more emphasis on the desires of the parents and more emphasis on the appearance of the child and the child's weight and breathing ability, things like that. They said, sorry that you felt pushed, but some families really are looking to let go at this stage when they're in that gray zone and a birth is imminent. And they said, well, what are some things we could say that don't bias the decision either way at this point? My suggestion was a phrase, your child is welcome in our nursery. It doesn't mean that you should put the child in the nursery. And I also use the word nursery because at that point I had no idea what NICU meant. I was pronouncing it NICU. And also they made it clear that our child might not be welcome in that nursery. And getting thrown out of a level 3 NICU is not like getting kicked out of a daycare. You can't go onto Craigslist and go searching for a new NICU. This being Swedish First Hill, in Seattle, I suppose we could have demanded an ambulance and been taken up to the University of Washington, but that wouldn't have been a particularly wise move either, transporting a woman about to give birth at 22 weeks. They also said that a decision that the doctors and the families arrive at as a team should be fully supported, and that they hadn't done that in this case, and they apologized for that. And that meant a huge deal to hear that they apologized for not fully supporting our decision to go forward and try to save the child. I also suggested that they provide, rather than just those gloomy national statistics I was telling you about, that they provide some local statistics as well. And then Dr. Beckstrom said, well, we could say that we have a 100% success rate with 22-week preemies. And that caused me to smack my forehead and say, okay, I see your point. Gabriel's the only one that has been through Swedish First Hill's NICU, and there haven't been any other survivors or non-survivors. And so, and then in the past 15 or 20 years, they've had about 23-weekers. So it's not that good of a, coming up with a statistical sample for that group is not that useful. I also suggested that they have a birth to 3 medical professional attend the counseling session. Somebody like a physical therapist or perhaps a pediatric neurologist who can tell the parents about what kinds of therapies children undergo and what kinds of lives they live with their disabilities, so that you don't have you have an actual picture of what a child might be going through rather than just impairment with this 2 nasty syllables in front of it, severe neurodevelopmental or moderate or profound. Also, I should point out, I didn't even know the difference between severe and profound. They had to explain to me that profound was worse. So, it's a whole new world that you're in when you're a parent in this process. Also, last year, at the same time I wrote to the Swedish Ethics Committee, I wrote to the American Academy of Pediatrics, and I wrote this in the summer, or I wrote to them in the summer, I should say. And then in the fall, they came out with a new set of guidelines. I won't read the whole thing to you, but it puts more of an emphasis on the parents than previous language had. And it also says gestational age of less than 22 weeks, which is a big deal. They moved the line from 23 weeks down to 22 weeks. And then going from there to make a decision that's in the baby's best interests. I don't know how much influence my letter had in the writing of this new document. I hope it had a little bit, but I was quite glad to see that the line had been moved. I'm also working on an editorial to the Journal of Pediatrics with a neonatologist from Florida. And this is the idea of the article is to write about how patient families and doctors can learn from each other and learn about each other's processes in coming up with a way to better do antenatal counseling. And so we're still working on the drafts of it, but what I have said, at least in my half of this editorial, is that we as parents were not really listening to the doctors that well. They were providing us with statistics about ability, but I said we needed to talk about quality of life. Anything that they would have presented to us as just pure statistics, we would have dug our heels in even further and demanded treatment. And if the only reasons we could have thought of to not provide treatment is if they told us that our child would have lived a life of extreme discomfort, perhaps a lifetime on a tracheostomy tube or with a colostomy bag, things like that. Might have made us not want to go forward with treatment. But as it was, we weren't actually talking to each other. We were sort of talking at each other. And so the idea of this editorial is to get parents and doctors talking with each other better. I also am advising that doctors seek out the motivations of parents. What is the primary reason you can think of that would lead you to ask for treatment or not treat? Some parents might go for the ability questions as to whether, how impaired the child is going to be upon leaving the hospital or getting up to the age of 2 or 5. Other parents, like our primary concern was quality of life. Other parents might be more concerned about financial issues. Not just the bills in the NICU, but also how do you leave enough money in your will to provide for a developmentally disabled adult. And when you've only got a few hours to think about something like that, it can be really overwhelming, and perhaps a visit from a financial counselor could be of help there. I also advised that doctors should ask which is better, a short goodbye now or a strong possibility of one in a week. And that is something that our doctor was trying to save us from, was an infant that lives for just a short time and then dies. He was of the opinion that is harder on the family than it is to say goodbye quickly and immediately in the delivery room. We would have felt worse about a child not given a chance, but there's multiple opinions on that. And I also am advising to talk about the baby by name. And in fact, at the time we had this conversation, the antenatal counseling conversation, we had picked out a name. We knew it was a boy. We knew we were going to name him Gabriel. So, okay, now I want to turn out the lights again, and I'm going to play a video for you. You're a very smart boy.
No, I am not. I am a math
What does that mean?
Hey, I am a mad boy.
Oh, I don't think you're a mad boy. You look like a happy boy to me.
No, I am not happy boy. I am a mad boy.
So,
He doesn't seem very mad.
do you believe him? So that's preschooler humor right there. Oh, this wordplay and switching from one to the other. So I'm going to show you now just a few photographs. That's the ethical dilemma I was talking about. And now I'm just going to talk a little about our experience in the NICU and some things that nurses did to help us, and some things just about what Gabriel went through. I'm thinking the lights would be better off for this than on, just because I now realize there's all these photographs in this section. So let's do that. So we had a 5-month NICU stay, and we called him the protected contact baby. And this picture was taken when he was 1 week old. And it was taken by a March of Dimes volunteer or professional photographer brought in by the March of Dimes. That they brought in the photographer once a month to make these fancy family portraits, which meant a big deal to the NICU families. We called him the protected contact baby because Miri is a zookeeper, and protected contact is a style of practice that they use in zoos. So that large animals can interact with the zookeepers but don't have access to the zookeepers. This is a picture from the Oakland Zoo. That's not Miri the bear, by the way, but this is an elephant getting his feet cleaned by a zookeeper, and you notice that the bar is there to prevent the elephant from being able to come all the way up to the zookeeper, but at the same time, the zookeeper can get access to the parts of the body of the elephant that she needs to. And so in the incubator, we felt like we had a protected contact baby, and that we were allowed once every 3 hours to reach in there and change the diaper and take the temperature, but we weren't really allowed to hold our baby, which was kind of a frustrating aspect of the experience. We had a 5-month NICU stay, which involved 5 weeks on the ventilator, and he did get bronchopulmonary dysplasia as a result. Bronchopulmonary dysplasia is a condition that really only exists in the NICU, and what it is the ventilator causes lung irritation. And so the question is the child's lung development going to outpace the irritation that his lungs are getting from the ventilator puffing air into them? He eventually did get past it. He also had patent ductus arteriosus, or an extra valve open in his heart that caused, it's not exactly a heart murmur, but it's sort of a relative of a heart murmur. It was corrected by indomethacin, which is a lot better than the terrifying alternative, which was open heart surgery and a stitch that they said was almost certain to catch and disable one of his vocal cords in the process. He got one infection that went septic, and that happened at about 30 weeks of gestation, at which point he was supposed to be beginning on feeding, and that held him back and caused us problems later down on. And he got stage 2 retinopathy of prematurity, which the range is stages 1 through 5. Stevie Wonder had stage 5 retinopathy of prematurity because when he was born, he was a preemie, and when he was born, the standard procedure was to keep him oxygen at 100% in the incubator, which interfered with the development of blood vessels in the eyes. He did not feed enough on his own, and so he ended up getting getting surgery for a gastric tube before he was allowed to leave. Thankfully, however, he did not get necrotizing enterocolitis or a brain bleed, and those two are the really scary conditions that happen in the NICU and which are also responsible for that monstrously high death rate. Here we have a picture of him at 5 weeks old. That mask that he's wearing looks far scarier than the one that he had in the previous picture, but it is far gentler to the lungs. It is a CPAP mask that puts pressure on his lungs and allows supplemental oxygen to be given to him, but it doesn't go down his throat and doesn't go puff, puff, puff at him. He has to initiate all of the breaths with the CPAP. This is something that happened. I had been staring at the incubator too long, and so I said, wouldn't it be nice if our son could go flying off on adventures and, with the Red Baron and things like that. So I said, wouldn't it be nice if his incubator could be like Snoopy's doghouse? And I made that. Here he is at 3 months getting a bath. He's got a vapotherm breathing support there, and he's starting to look more like a baby rather than a wrinkly old man. Here he is at term equivalent, and we actually caught him giving us a smile. Here he is going home, and that's Miri taking him outside for the very first time in his life after 5 months. Since this is a nursing school, I can tell you about several things that nurses did that made a big difference for us. One was saving holding tasks for when we came. And one of those examples was when he was 2 weeks old, it was time to change out his incubator because every 2 weeks the incubators get taken away to be cleaned. So that involves 3 or 4 nurses holding the baby, taking apart the incubator and then reconnecting everything to get him into the new one. It takes about 15 minutes. They waited until we came, and Miri got to be the person who held him for about 5 minutes. And that was a huge deal for her because they had let her hold Gabriel for about 5 seconds after he was born. And at the time she was holding him, she was crying and saying, the thought in her head, she told me later, was, take him upstairs now and get him hooked up. There's no time for this. And so she actually got to hold him and admire him and things like that. It also helped us a great deal when they used neutral words such as, he's acting his age, when the desaturation alarm went off. And the desaturation alarm is something that parents learn to hate very early in their time in the NICU. And it goes off every time the baby's blood oxygenation goes down below a certain level, and then the nurse jumps up and turns a dial and increases the oxygen. And that desat alarm going bong, 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 well, what it means literally is that your child's asphyxiating and can't get enough oxygen throughout his body. But they didn't say, oh, don't worry, it'll be fine, because of course it wouldn't. And they didn't say, oh, he's asphyxiating. Thank God they didn't say that. He's acting his age. That's what a 22-week preemie will do. They also took me seriously when I noticed something odd about the baby. I was changing his diaper once and noticed that his scrotum seemed to be larger than it should be. And I said this to the nurse, and she said in a very serious tone, I'll tell the doctor, and the doctor will order an x-ray. I thought, oh dear, have I just, disputed with the professionals here? And the answer is no, she was just taking me seriously. And the x-ray did in fact reveal a hernia. And the fact that I was taken seriously when I said that meant a huge deal to me, because I could be an advocate for my child as well. Also, they told us you won't hurt him when it came to diaper change time and temperature taking time. When we first saw him in the incubator at a few hours after he was born, we thought, oh my goodness, this child's just going to fall apart if you touch him the wrong way. And he was, of course, very fragile, but at the same time, you could change his diaper without causing major damage. It was also helpful to have them as an advocate for us when the doctor forgot about us. In one case was congenital adrenal hyperplasia was diagnosed. Turned out to be a false positive, which is actually a pretty common thing to happen in the NICU. And 6 weeks later, we're saying, well, what about that congenital adrenal hyperplasia? Or no, it wasn't 6. It was more like 12 weeks later. And they just kept like, okay, we had the menacing visit from the endocrinologist telling us that our child could never, manage his salt or his fluids correctly. And we eventually, that nurse did get us the phone calls necessary to find out that it didn't appear to be an ongoing problem. And lastly, a suggestion is to figure out how to balance, if you're a NICU nurse, how to balance HIPAA, the privacy laws, with helping parents understand the NICU neighborhood that they're in. At Swedish, the incubators are about that far apart. And there is a chair you can sit in between them and look at your baby. And then the baby next to yours may be having an absolutely awful day with nurses swarming about with bloody gauze everywhere. In fact, that did happen one day with the bloody gauze. And I said to my baby's nurse, boy, how much longer are they going to be doing that? Is something serious going on over there? Should I be here? And just can't tell you. And so there's this poor mother over there having the worst day of her life, and I don't know if I should be there. Should I say something comforting? Should I say, hi? Should I not? No help. They can't talk about it. I understand privacy, but there needs to be some kind of an understanding, especially when you're going to spend that many months as immediate neighbors to other families. He now has a feeding tube for most liquids, although in the past month he's made considerable progress on drinking through a straw, and in fact doing it with minimal coaching. He eats yogurt by mouth, but eats by mouth, but he's stuck on purees for foods. That video of him in the grocery store was Trader Joe's, and he was getting their full-fat Greek yogurt, which is the nectar of the gods for that kid. It's very high in calories, and it costs $2 per bin. And when one Trader Joe's would be out of the stuff, we would go, Federal Way, Issaquah, University Place, Kent. Where's your yogurt, darn it? He has small kidneys, which a nephrologist has diagnosed as stage 1 kidney disease. He's also very slender. The nephrologist has thought that is great. The dietitian and gastroenterologist have called him malnourished as a result. And that is another experience of preemie parents, is being tugged in 2 different directions by 2 specialists. At the age of 3, he was admitted into developmental preschool in his district and is to deal with speech delays, and he's making considerable progress in catching up. Let's see. Then this is the part where I advertise my wonderful email newsletters and talk about how I send out these email newsletters about once every 2 or 3 weeks, talking about my progress as a speaker and trying to get the book published and about things going on in the world of preemies. And then lastly, this picture. I'll leave that up for a while. This picture is taken from the day, the very first time Miri got to hold him for 5 minutes. When they did that incubator disassembly and reassembly. And so this is really our first family picture. So I'm going to stop here and